Hello, everybody, and welcome to today's webcast for Myeloma Week, Myeloma Research, What's New? We'll get started in just a couple of minutes. We're just going to let a few folks roll in, and then we will begin today's presentation. Welcome to the Leukemia and Lymphoma Society of Canada's webcast, Myeloma Research, What's New? Today, Dr. Donna Reece, hematologist at Princess Margaret Cancer Centre and University of Toronto, will share about current and new treatments for myeloma and will highlight what is being done to improve the quality of life of myeloma patients in Canada. Let me introduce myself. My name is Alexandra Clark, and I am the Community Services Lead for West Ontario. I will be the host of today's online event. Since there are many of you who are in the audience, we invite you to type your questions and comments in the question box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions. I will read aloud some of your questions at the end of the presentation during the question and answer period. Due to the large number of participants and limited time, we may not be able to answer all of your questions. Also, please note that our speaker cannot answer specific questions about a person's health status. Case-specific questions will not be read aloud during the question and answer period. If we do not get to your question during the live presentation, a community services lead will contact you directly after the webinar. Today's presentation will also be recorded. Therefore, you can listen to it again on our website. Before we begin the main presentation, I would like to share with you our mission and highlight some resources that might be helpful for you or someone you know. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their families. We listen attentively and with compassion to the challenges that you are facing. We can point you to information specific to your type of blood cancer or treatment. We can help you to get organized, to manage and take charge of your care, and we can identify services that will be beneficial for you. Don't hesitate to contact the community services lead in your area to learn more. Next slide, please. Our website, bloodcancers.ca, was designed with you in mind to ensure easy and personalized navigation no matter your current circumstances. Next slide, please. On our website, you will find fact sheets and booklets, animated educational videos, webcast recordings, podcasts, and much more. Visit www.bloodcancers.ca to access any of these tools. Next slide, please. Another resource that can help you is the LLSC Health Manager app. This free app can help you to track side effects, medication, administration, food and hydration journals. The app can also help to offer medication reminders and has a nutrition meal planner along with many recipes to help you to get the nutrition that you need. The app also allows for caregiver access and is free to download in the App Store on Apple or Android devices. Next slide, please. Our virtual support groups from coast to coast are a safe place to share experiences and to inspire and encourage others also affected by a blood cancer and their caregivers. Our groups are professionally facilitated. Please visit our website, bloodcancers.ca, to learn more and join. Next slide, please. It is my pleasure to introduce our speaker today, Dr. Donna Reece. She is a professor of medicine at the University of Toronto and director of the program for multiple myeloma and related diseases in the Department of Medical Oncology and Hematology at Princess Margaret Hospital and the University of Toronto. She holds the Molly and David Bloom Chair in Multiple Myeloma Research and is past chair of the Multiple Myeloma Clinical Trials Group of the National Cancer Institute of Canada, co-chair of the Myeloma Working Committee at the Centre for International Blood and Marrow Transplant Research, and member of the Board of Directors of the International Myeloma Society. Dr. Reece has spearheaded the development of the Canadian Myeloma Research Group, the CMRG, which contains a large national myeloma database and conducts national and international trials in this disease. Thank you so much for being here today, Dr. Reece.
Thank you. It is my pleasure to be here, and it's an honor to participate in Myeloma Week as we all strive to increase the awareness of this important disease. Now, this next slide is a brief outline of the topics I'm going to touch upon. I won't have time to delve into all of them, but I think understanding where we are in myeloma research today requires a little understanding of myeloma biology, a bit of understanding of where we've been with our previous Canadian approach to myeloma patients. And I won't have time to go through our database results in detail, but we've found this a useful tool to see how we've been doing in the past 15 years for our myeloma patients. The real excitement and the real research thrust has been in immunotherapy. And I'm going to talk about monoclonal antibodies, the ones that are already on the market, so-called naked, but these have been rejigged and made more sophisticated by adding a warhead to them, so-called conjugates, or these new entities called BiTEs or bispecific T-cell engagers. And I have a few cartoon pictures to show how these work. Of course, CAR T-cell therapy is an exciting new treatment that has revolutionized the care of lymphoma already. And I won't have time to discuss in detail, but there are also pills, the so-called CELMoDs, that are very active immunologically to complement the spectrum of immune platforms for myeloma. I'm also going to try to highlight this wide swath of treatments in specific settings of myeloma, because we treat younger myeloma patients. Those are less than early 70s. We have called them stem cell transplant eligible traditionally, or older individuals who need less intensive therapy as frailty becomes an issue with advancing age. And then, of course, the other setting other than newly diagnosed individuals is very advanced disease when nothing that's available now is effective anymore. I won't have time to talk much about the better ways to measure the myeloma burden. We are getting better finally at defining risk groups. We have a way to measure on a visual image the myeloma burden in patients, because the disease is everywhere. The bone marrow is everywhere. It's not a lump somewhere that we can watch grow or shrink, as in most other malignancies. Also, there's much excitement about being able to detect tiny amounts of myeloma in the marrow, so-called MRD. I won't talk about much yet because using this to make treatment decisions is very much in its infancy. And then there are new blood tests to get rid of the old M-spike, SPEP, free light chains. One of them is called mass spectrometry. And then I will briefly elucidate on what trials are available in Canada, because this is a mission of many of us in the field: get drugs to Canadian patients as soon as possible. So what is myeloma? I think you heard this from Dr. Ryman yesterday. It is a proliferation of these cells that are normally in the bone marrow in small numbers. The rest of the cells are making all the blood cells, but there's an overgrowth of a plasma cell that is programmed to make one antibody to fight one target. And this grows, and then the more cells there are in the bone marrow, the more antibody produced. Most patients produce a whole antibody here. It has two binding sites to stick on the same target, and it's used as a tumor marker. That's a good thing. It's a blood or urine test, but it has many limitations. This is not an inconsequential disease, despite the fact that it doesn't have good name recognition. There are over 4,400 new cases diagnosed each year in Canada, and I think a startling figure to me is every day 11 of us are diagnosed with myeloma. And as people live longer, the prevalence, the number of people living with disease is going up and up. It is a disease of older individual. Survival has definitely improved as I've I'll show, but cure has been elusive. We are getting closer though. I think most of you in the audience understand the main manifestations. 70+% of patients have bone damage, these holes in the bone surface. They're not really holes, they're thin areas, lytic lesions, anemia. You can have decreased kidney function, high calcium, and a risk of infection, which is getting more important as our new treatments also render individuals sensitive to infection. And we're learning ways to balance that risk against the benefit of these drugs. Now, many of you who've heard me speak over the years know I often try to preface any talk by saying myeloma is a heterogeneous disease. It is not one entity. The cells look the same under the microscope, but it's heterogeneous between patients. We use the International Staging Score. You can add fish cytogenetics in the marrow cells to try to define it. But this is only the surface. You have to look at what mutations are within these fish changes to really hone in on risk group. And I'll touch upon this briefly, because if you don't know the nature of the enemy, you don't know the best way to treat it. And we found new mutations that don't fit, they don't go with the fish changes. Now, within patients, I'll show this in a minute, the disease is different at different clumps of myeloma potentially in the same person. And then I'll show this on a graph. At diagnosis, most myeloma patients have 5 to 7 subclones. They're all myeloma, but they may change which one is leading a particular relapse. And then over time, the genomics can change, the fish can change, and the clinical features can change. Someone who's been monitored by an M spike, the myeloma cells over time may forget how to make half the antibody, and we have to follow free light chains. Or the disease stops making any marker, and we have to look at PET CT or marrows, and then the disease can leave the marrow, so-called extramedullary. Now, this just shows an old study that biopsied different sites of myeloma, and you can see they had different cytogenetics, even though they're all the same disease. And some of these may be faster growing than others. This is an important point. Each of these pieces in the pie in one patient represents a subclone of myeloma. Red is there at diagnosis, but then at treatment, the green subclone predominates. And then with more treatment, you drive to orange. And in this individual, it's a sliver of blue here that overtakes all the marrow population and becomes the most aggressive terminal form. So we need to be aware that the disease changes, and we need to keep ahead of it. So just a word about risk. This is a subject near and dear to my heart because it's not the same disease. Most of people in Canada, fortunately, have FISH results in the bone marrow, and we recognize now 5 risk groups. And I put in parentheses at diagnosis how many myeloma patients, what percent has each of these abnormalities. And I've shown pictures of what the FISH looks like to the technician reviewing it. But not everyone with these high-risk FISH has a worse course of the disease. It counts how many of these one has. And now we know that we've heard for years that 17p is bad. But when you do the mutational studies, it's only 1 in 4 that have more aggressive disease. And for years, we've been telling people, oh my goodness, you have 17p. Only a quarter really have the more aggressive biology. Same with 414. Only a quarter, when you look at the mutations with a different type of test, more sophisticated, are really so-called high risk. And we want to get it right for patients' peace of mind and giving the right therapy to the right patient. Now, one of the things that we've integrated at Princess Margaret, and this goes along with research, is a panel of gene mutations that we can run on bone marrow cells, and it will pick up the key mutation, the key FISH changes that we can by the slide I showed before, but also a variety of mutations using other techniques that can identify better or more worrisome subgroups. And we're doing this now using philanthropic funds to better hone in on our patients, particularly that we think have high-risk fish. And to me, this is a big deal. We don't want to overtreat people, but we don't want to undertreat them. Now, when I first came to Princess Margaret in 2001, all we had was this old VAD stem cell transplant, hard to get thalidomide, and alkylating agents. And you can see a rapid development of new drugs. And just so we have a common vocabulary, I've listed these drugs and their classes, their abbreviations for the classes, and then the brand names. I was always taught you use the chemical name, but many of us refer to these drugs always that bortezomib is going to be Velcade, but I will try to use the chemical name, not the brand name. But you can see we have multiple classes now. And it's important, I think, for the audience to know this, because the newer drugs may require exposure to 1, 2, 3 classes. And that defines who is going to have approval and funding for these drugs. The main 3 classes are IMiDs, PIs, and CD38 antibodies. So I know you heard yesterday about myeloma management. I'm just going to try to summarize what we've learned over the last decade. I've already mentioned the heterogeneity. We need lots of treatments to match the right treatment with the right patient. And until the disease can be reliably cured, progress has been dependent on the use of different regimens in some sequence, milking all we can out of each line of therapy until it quits working, to suppress the disease damage, but maintain quality of life, so we're not making our patients suffer from side effects. And by stringing these along in sequence, I say like beads in a chain, we have helped people live longer. Until, well, I will say virtually all the studies that have been done, unfortunately for our patients, have shown that giving continuous suppressive treatment until we can cure the disease versus a fixed duration of 6 cycles, 8 cycles that work so well in lymphoma or certain leukemias is the way to go. And I just show our CMRG database. This was presented at ASH by Julie Cote in Quebec City, using our database for 15 years of transplants that showed that if you had maintenance, any kind of maintenance, your progression-free survival was much better than if you didn't have maintenance after a stem cell transplant. I'm sorry, this is the progression. It's almost double how much longer the disease stayed in control, usually with one oral drug, Revlimid or lenalidomide. And this is translated into a survival benefit. Now, of course, we need to keep the symptoms down, but this idea of continuous administration is quite different from other cancers. We now are in the era of giving 3 drugs, not 2 drugs. And so historically, we've used a backbone of a PI and DEX, that's a doublet, added a new drug. You can do an IMiD and DEX, add a 3rd drug, or you can combine a PI and IMiD. And these have been identified as some of the more potent regimens until the new era. Now we're moving to quadruplets. You add particularly an immune agent to one of these triplets, and you get what's called a quad. And as I said, antibodies and other immune treatments are usually this 4th drug, and they have been a game changer. So this is our current algorithm. I won't belabor it, but in Canada, Europe, Australia, we still find the data shows that doing a transplant up front, not delaying it until relapse, gives the best outcome in terms of the longest initial disease control. We have more treatments available for transplant ineligible or older individuals, but eventually the vast majority of people will have a progression. And if only patients who have had eligible for DARA Cyborg-D or DARA lenalidomide have had a CD38 antibody. So we really try to get it in second line. That's where we have funding. After that relapse, we tend to rely on carfilzomib, pomalidomide, even more reuse agents. Usually by this point, we don't have the option for funding for a CD38 antibody. So what about the integration of immunotherapy? As you probably know, new treatments are first approved in a very advanced setting after so many lines of treatment. And then I've already mentioned we have to look at specific drugs that patients have received or drug classes. And the terms refractory relapse are popping up in eligibility for trials and new drugs, which means the disease has progressed on the treatment, implying that it's outsmarted it. The tumor is resistant to this. They'll define within 60 days of stopping it. So if a patient is progressing on lenalidomide, that's a necessity to be eligible for funding for pomalidomide. A non-refractory relapse is the disease that's progressed after exposure to a drug, but it's been stopped for a reason other than relapse. And a reason may be a patient is going for transplant, they get 4 or 5 cycles of Cyborg-D, they respond, you stop it, do the transplant. They are not refractory to bortezomib or cyclophosphamide, they're exposed. And these terms are getting to be quite important about who can get what. The newest immunotherapies are currently being positioned for those who are triple class exposed. Those are those big 3 I mentioned, PI, IMiDs, and CD38 antibody. They were also designated how many lines of treatment, like I showed in that busy slide with all the different algorithms. And some require that you're progressing on the last line of treatment. Now, as these new treatments are shown to be effective in advanced disease, we're moving them earlier and earlier into the treatment sequencing. And now we have CAR T-cell trials ongoing in newly diagnosed patients who are not transplant eligible. These are generally older individuals, and in newly diagnosed patients that are going either after or now instead of a transplant. So this is unprecedented in the speed that research has integrated these novel, exciting treatments from those who had no other options to part of the first line treatment in a matter of a few short years. Now I'm really going to move into the actual new agents and type of agents. This is a myeloma cell, and these different figures on the outside represent just different proteins and markers that are on the surface of a myeloma cell. And you'll recognize some of these, but they are identifiers because we want to find markers that are only on myeloma cells or plasma cells. Now, BCMA and CD38 are quite good, but these markers may be on other cells, because when you're developing an antibody against these markers, it's not only going to stick on the myeloma cell, but it will stick on the other body cells that happen to have one of these markers on it. So we have to keep that in mind. Now, it's always paradoxical to me that we're dealing with a disease that the bone marrow makes an excess of one kind of antibody in large numbers, a monoclonal antibody. This has actually been exploited to make these treatments that they vaccinate an animal with one of those target surface molecules, then collect antibody forming cells from the animal and fuse them with myeloma cells that have been obtained in the lab. And then you have little factories of different antibodies, and the technology selects the antibody that sticks on the tumor the best. These are called the hybridoma method. So in the lab, you have these little factories of fused myeloma cells, and we're not giving these cells. You can't give someone a disease from this. We collect the antibodies, but we have these monoclonal antibodies for several cancers now. They've revolutionized the care of lymphoma, Rituxan. And we finally have antibodies for a disease that makes antibodies. And you can make these humanized, so they're not antibodies from animals per se. So the first monoclonal antibody that was developed for myeloma was against SLAM-F7. That's just this marker here. It's a drug called elotuzumab. There are a number of studies done of it in Canada. Some of the people in the audience may have had these studies 5-8 years ago. It works reasonably well, but it was expensive and the company never marketed it here, which is interesting and was disappointing at the time. But now, better or more effective monoclonal antibodies that are directed against this guy here, CD38, are now marketed in Canada. The two products are daratumumab, or Darzalex, or Dara, we nickname it, or isatuximab, also known as Sarclisa, and we call it ISA for short. So these three antibodies, and I'll ask you not to pay attention to elotuzumab. It's not available, and it's not as effective in killing myeloma cells as the other. But to give you an idea of how these work, you have your myeloma cells, you infuse intravenously or subcutaneously these antibodies, which are shown, that's supposed to look like that Y-shaped thing. And what this does, this coating here, is it calls in the troops. It calls in other cells in our immune system that attack the myeloma cell. I often say these antibodies, when they stick on, they raise the flag and tell the different platoons of the body's defense system to come in and kill it. Now, this is what happens when you have antibodies to kill a bacteria or COVID virus. It's the same principle. So there's a variety of ways, without chemicals, without chemotherapy, without those side effects, that you can almost hijack our immune system to kill an unwanted cell, which is really, really cool. And we don't have all those unpleasant chemotherapy side effects with hair loss and nausea and vomiting. There are side effects, but they're quite different. Now, the timeline of CD38 directed antibody approvals in myeloma is shown here. Now, this is actually a US timeline, and you can add a few months or years, mainly a few months, for Health Canada approval. But then we have to get funding because these drugs are expensive. But really, a landmark study showed the benefit of adding DARA to lenalidomide and dex, also called RD, one of our backbone doublets for myeloma treatment in transplant ineligible patients. This is called the MAIA trial. So this, here's your monoclonal antibodies sticking on the malignant cell. But recently at our big meetings at ASH, we finally got the results of these 3 drugs on disease control in newly diagnosed patients. That was over 5 years. And you can give daratumumab subcutaneously under the skin, and it's down to once a month with 2 pills, which is just amazing. And now the overall survival advantage, the median, that's the number or the figure or the parameter we use. Half people are still responding, half people are not. It's just our way of trying to get an idea of how effective something is. The response rate with what we call DARA-RD is almost 93%, compared to 80% with just RD, which is oral. So I'm not going to go into MRD negativity, but that's just a deeper remission. And interestingly, MRD isn't that high with this extremely potent regimen. And I think it points to how getting a deep remission is good, but keeping the pressure on the myeloma cells continuously is what's needed with some agents. Now, just to put this in perspective, and this goes back to that diagram where I had all the yellow orange boxes showing our treatments that we have available for transplant and eligible newly diagnosed patients, CyBorD, RD in different trials, RVD light with weekly bortezomib, twice weekly bortezomib, and then the DARA trials. And this is what the trials showed, median progression-free survival. Now, what we've done in the CMRG database, which I think I said has over 9,000 patients, is we've looked at our hundreds or thousands of patients, not on a clinical trial. They're not screened for good kidneys. You know, these include all comers, people that were on dialysis, you know, just who comes into our clinic. And I think what's very reassuring is even outside clinical trials, our outcomes in the real world are very close to the clinical trials, surprisingly close. Now, this is reassuring information to give our funders, because it says when they make a decision to fund a drug, they use these figures, and that's what we're seeing. We recently got RVD, Lin, bortezomib, and Dex for elderly patients, not yet reached. We've only had it about 3 years. And we will be looking at this incredible outcome for non-transplant patients. We've had funding throughout Canada beginning about last spring. And of course, Ontario was the last to get this funded. So I think this is an incredible advantage from about 2 years, which looked awfully good in 2005, 2008, to over 5 years just for the first disease control period. Now, what about transplant eligible? There's another trial that has added, as shown here, many centers use Lin, bortezomib Dex before transplant. You can give it for a couple of consolidation cycles, your transplant, and then we are using lenalidomide maintenance. I've shown you how effective that is, and we have used it. We've tended to use CyBorD, although all provinces now have RVD funded except Ontario, although we are finding ways to cobble it together. It is a bit better than CyBorD. But the Griffin trial added DARA here and maintenance up to 2 years, but I understand from participants that the lenalidomide maintenance was continued off study, which means it wasn't paid for in the trial, in virtually all patients. So they stopped the DARA at 2 years, they continued to Lin. But this is a randomized trial. It's a randomized phase 2, which means our funders won't like it as much. But whereas normally we see a median PFS with other regimens somewhere around 4.5 to 5 years, we haven't quite gotten there. For DARA RVD and a stem cell transplant and 2 years of DARA maintenance, we're almost 90% free of disease progression at 5 years. This is unprecedented. So I think in comparison, and I haven't gone through all the details of our own studies, we've done detailed analyses of our own country's outcome in high risk, tandem transplants, maintenance, no maintenance, but this has definitely moved the needle for where we need to be for our transplant eligible patients. So,
excuse me, Dr. Reece, about 15-20 minutes left. Just wanted to give you your note.
Thank you. As I said, I can talk forever. So what keeps me awake at night, one of the things is how can we get CD38 antibodies into our transplant sequence as soon as possible? We have had a CMRG trial that adds ESA to our current backbone to Cybor D, and again at maintenance until progression. There's another trial in several centers that randomizes, so only half of the patients get daratumumab. If after a stem cell transplant, they still have evidence of disease by MRD, they're randomized to lenalidomide or lenalidomide and daratumumab. So moving on to one of the most exciting areas, I've talked about CD38 naked antibodies. We now have more sophisticated antibodies. We could say antibody drug conjugates are a monoclonal antibody, but they've added a toxin to it, a warhead. So this sticks on those markers, usually BCMA, and then injects the poison there. So you kill the myeloma cell not only by the immune mechanisms, but by putting a poison into it. Bispecific antibodies, we also call BiTEs, can be targeted against these markers. These are the ones that are on trial in Canada. This has been submitted to Health Canada for approval. Elranatamab will, if not submitted, will do so very soon. And then I'll talk briefly about the 3 CAR T cells that have been studied in Canada. So BCMA is the target I'll speak to here. It's present on really all plasma cells. And for the antibody drug conjugate, the main drug is belamaf. This is our Canadian trial, CMRG, that combines this conjugated antibody belamaf with pomalidomide and dexamethasone. I just wanted to point out this is a made in Canada trial. There've been 100 patients treated so far, more than 100. This drug is annoying in that it causes some eye toxicity that is always reversible, but it is annoying. But still, the overall response rate is 88%. And the median progression-free survival is almost 1.5 years. And if you compare this monoclonal antibody to those with PomDex, when you give Dara or ESA, you can see 1.5 years, a year. This is very promising and being studied in a phase 3 trial. And despite the eye annoyance, this trial has helped a lot of Canadians until we can get access to more antibodies. Now I'll talk about bispecifics. Most of the antibodies, the 2 arms stick on the same target, but in a bispecific, 1 arm sticks on the tumor cell to one of these surface antigens, our surface markers, I've already described it, usually BCMA, but the other side sticks on a killer blood cell, a lymphocyte called a T cell. These 2 are brought side by side, and this cell says, I'm going to kill you. And it releases these little substances that then penetrate and kill the myeloma cell. Now, I say there's smoke and fire in this, and that leads to this syndrome that we call cytokine release syndrome, or CRS. And it's like a bad flu, fever, chills. It can be more severe with low blood pressure. Patients feel crummy. Rarely it's very severe, but the bispecifics in myeloma, the CRS is usually milder, shorter, and manageable. Our antidote is a drug used for rheumatoid arthritis that neutralizes some of these fever type effects, or steroids. There's another neurologic effects that occur from all this smoke and fire. I'm sorry, there's a typo here, that can also be treated, and I'll show you the incidence of these. It's become quite manageable. And aside from the first doses or 2, this can easily be given in an outpatient every 1 or 2 or 3 or maybe even monthly. The advantage of these bispecifics, if there's off the shelf, you can order them. Some you can give under the skin, and you can give them over and over again. And then you can go through one that targets BCMA. And then when that quits working or doesn't work, you can pull another bispecific off the shelf and target another marker on the myeloma cells. So you can use them together, that's under study, and you can use them in combinations with our older drugs. And I've just shown you all the bispecifics, but I'm going to concentrate on the ones we've had in Canada. This is an update of all the bispecifics that just target BCMA. And the two that we have studied in Canada, although the others will be coming, are teclistamab and elranatamab. I will point out that these are studied in patients who've had at least 5 lines of treatment. They are refractory in the vast majority to all 3 classes. That means they haven't only had them, the tumor's grown on them. In general, the overall response rates are in the 60% range, which is remarkable. If you look at standard of care treatments, the response rate is very low and the duration is about 4 months. Now, we don't have the progression-free survival or duration in all of those, but we do have, for those 60% responders, you can get an advantage of like 1.5 years. This is unprecedented. And yes, there's some CRS in the majority here. The dangerous type or the higher grade is very low. Neurotoxicity, very low in the high grade. The real thing we need to watch for is infection. And that can extend throughout the course of the treatment. It does cause some neutropenia, low neutrophil count, but that can be easily managed with growth factors like G-CSF. So there's another target. This is one of the other main bispecifics that targets GPRC5D. Note that this is also on hair follicles, some of our surface cells. And this is a very busy slide, but the drug that targets this marker is called talquetamab. So we call it TAL, and you'll notice all these studies are Monumental as a nickname. Now, they've studied different doses, and you can see here it's given weekly. Here it's given every 2 weeks to try to, not have patients come in as much. And the duration of response for those that respond, which is generally, again, about 60%, sometimes 70%. Once you respond, follow-up is not that long, but you can see people are responding a long time for patients that have had way too many lines of treatment that we would not expect this. Now, because GPRC5D is on not exactly skin cells, but lining cells, we see some cross reactivity on the cells lining the mouth, the cells lining the gut, the swallowing tract, skin rashes, sometimes peeling skin, or nail changes, fingernail changes. These are manageable, but it's a new toxicity. And I won't ask you to go too much into this, but to make the point that for patients in this trial, TAL1, who had received prior CAR-T against BCMA or other bites, they still had response rates of 35 to 70%. And even those who had progressed after prior CAR-T were responding to these, which is incredible. So if we have all these new bispecifics and CAR-T, one can imagine that the treatment options have expanded greatly for patients that there were none after POM, carfilzomib, Dara. Another one that targets FcRH5 is called cevostamab. That was the first one we studied, and we've been studying that. We've had trials for well before COVID. And one of the interesting facets of cevostamab is it has always been studied to date to be given only for a year, which has much appeal for patients living with this disease. Now, there's a lot of focus now on getting rid of CRS, because that's what means the patient has to be admitted the first dose or two. And this trial that was presented by Suzanne Trudell in my group gave 1 dose of the antidote, toci, 2 hours before cevostamab. And they did a comparison with a historical group of patients who just had the usual pre-meds, which are the usual, Benadryl, Dex, Tylenol. And what they found is the incidence of CRS, any grade, went way down, 90% to 35%. And very few patients had the green, the higher toxicity, and no one passed away from it. There was more neutropenia in the toci arm because toci knocks down the white count a bit. It was manageable, and it didn't compromise how well cevostamab worked. So there is a number of trials and different bites or bispecifics trying to mitigate CRS. Now, I just shown you here, you add cevostamab and talquetamab. So that's your monumental. And again, you can compare. My only point is all these trials were done in advanced patients. Most were triple class refractory. Overall response rate, you give the better cevostamab, it hovers around 60, 70%. You can't tell much difference from these. Median, we have some a year here duration of response for cevostamab, some updated information on tau, and I think I showed you on teclistamab, it was 18 months. So it's hard to say, one is better than the other. So for my patients, my goal is to get a bispecific. We usually don't have the luxury in terms of our trial access to say, oh, if someone's urgently ill, we can't say, well, let's wait for a spot for tau. We have to take what we have, but they're all good, and you can use one after the other. Now, I will just show briefly the studies that we have at Princess Margaret there, and to show that how these bites are now being moved up from what I just showed you, 5 or 6 lines of treatment, triple class refractory, to our Majestic 4 trial, which will be done with CMRG's collaboration with the European Myeloma Network. This is a 1,000-patient trial that after transplant, patients are randomized to the old lenalidomide maintenance versus teclistamab alone versus len and tec. And this trial was about to open. It's been delayed a bit. Not to be outdone, the elranatamab trial, these are the magnetism trials, will randomize patients who are MRD positive after transplant only. This is all comers to either len, Revlimid maintenance single agent versus elran single agent. So we're beyond lenalidomide maintenance. For early relapse, we've just put on like crazy, maxed out the number of patients on Majestic 3. Patients are randomized to pomalidomide, dex, and dara, which is not yet funded. We hope it will be, versus pom, dex, teclistamab. Very exciting study. For advanced relapse, I won't go into all of them, but again, elran with or without lenalidomide, or cevostamab with the toci pre-med to try to mitigate CRS, cevostamab with pomalidomide, cevostamab with dex. So you can see the absolute incredible activity all at once for this field. I know I'm running towards the end, but CAR T is a very hot topic. This is quite a bit more involved than a bispecific, but is kind of the ultimate way to make T cells kill cancer cells. So you collect lymphocytes from a patient. It's done just like you collect stem cells from a patient before a stem cell transplant using a pheresis instrument, but we set the dials differently. We don't want stem cells, we want lymphocytes. We refine these to collect this particular family of lymphocytes, T cells. They're sent to the lab and they're reprogrammed to attack a certain surface marker. A problem, this takes 5 weeks, but then you can expand these T cells. A patient right now receives what's called lymphodepleting treatment. This is pretty high dose fludarabine and cyclophosphamide, not necessarily to kill myeloma, because all cancers get this that receive CAR T cells, but to let these cells have an advantage to repopulate. You give them back to the patient. There is definitely more smoke and fire with CRS. There's more neurotoxicity, but compared to some other diseases like lymphoma, where CAR T is appearing to be curative, it's now funded in certain situations, we have less toxicity in myeloma. There are many challenges. For the CAR T cell platforms that are available for myeloma, particularly ide-cel, very limited production capacity versus the demand in the US. This is still not easy to give as an outpatient. So we don't have a unit easily in every hospital for CAR T cell. If your patient is rapidly progressing, and these are limited to people who've had 4, 5, 6 lines of treatment, it's usually 4. The disease may be growing quite quickly. You don't have an easy 5 weeks. You can give so-called bridging therapy, but the way these are positioned for approval and funding, a patient has to have already had everything. So it usually doesn't work, and you can only give it 2 weeks. I've mentioned the side effects. Patients do have low blood counts for a period, and occasionally it can persist. There is a risk of infection, and the CAR T cells don't necessarily live that long. And that doesn't seem to be a problem in lymphoma, where they come in, do the job, and may die off, fizzle out. But lymphoma is curable anyway. Myeloma, we've tended to need to keep the pressure on. Late toxicities we're learning about, and this is a costly procedure, not only for the CAR T, but all the supportive care around it in hospitalization. Now I'm going to walk you through the last couple of slides, the a history or the perspective of CAR T in myeloma. We did do the KARMA trials. These are the BCMA-directed product that was developed by Celgene BMS. And this, we actually did this trial at Princess Margaret. It's proof of principle that this strategy can produce remissions in incredibly advanced myeloma. I've seen it. The study had a median line of 6 lines of treatment. Overall response rate, not just complete responses, was quite high. Median PFS, proof of principle, but I think given how progress in the field has gone, it is arguably a home run, particularly for a very expensive treatment. But if the minority of patients that had a complete or stringent complete remission did have a benefit, just under 2 years. So this is proof of principle, very exciting. This was approved by Health Canada, but turned down by funders. There are lots of ways to try to improve the outcome of CAR T. One of the important ones is to use earlier in the disease course, and my last slide will show how this is happening. However, what was just approved yesterday by Health Canada is the second CAR T cell platform called cilta-cel. It's just a CAR T that attacks BCMA a little bit differently, a little bit different part of the BCMA surface marker. Again, 6 lines of treatment, overall response rate almost 98%, stringent CR 67%, MRD negative 92%. Almost everyone had CRS, low percentage of high grade. There is more neurotoxicity. 9% were high grade, but the updated progression-free survival is over 2 years, and if you're in a deep remission, it's even longer. This makes everyone sit up and take interest, because if this is in stage situation, to get 2 years is amazing. Now, the cost, I just looked it up. It's being priced at $467,000 for the product. The hospitalization costs for TOSI, which may need to be given several times, IV antibiotics, transfusions, potential transfer to ICU in the US has run $500,000. So
Hi, Dr. Reece. Just about 5 minutes left before our question and answer period.
Thank you. I think I'll be fine. So you have a product that the whole package is going to be $1 million. And, you know, other research drugs, you just pay for the drug because you don't need to add much to your healthcare system to take care of patients. Here you need new units, new trained staff, new processing, expensive antibiotics, blood transfusions, etc. And that has to be covered by the healthcare system. But these are really remarkable results compared to what we had a few short years ago. What are the CAR T-cell trials in Canada? Several centers, including ours, have done CARTITUDE-5, which was initial therapy in patients not planned for ASCT, what we would call in Canada transplant ineligible, generally older individuals. And patients had lenalidomide, bortezomib dex induction, and I'm sorry, a typo here, then randomized to either cilta-cel or more RVD to complete a number of months, and RD continued on. I think we put 5 or 6 patients. So these are randomized. Not everyone gets CAR T. We're just about to do CARTITUDE-6, which is in transplant eligible patients. And this is an all-around good deal because the induction is DARA RVD, what we want from the Griffin trial. It's going to take a long time for that to be funded in Canada and other countries that have careful health health cost effectiveness assessments first. So they get a quad and are then randomized to cilta-cel CAR T or a stem cell transplant. And I think they get lenalidomide maintenance in this arm, not this arm. So it is possible we won't be doing stem cell transplants in a few years. The other CAR T-cell product, KarMMa-8 trial, for patients that are MRD positive after a transplant, they're being randomized, and this trial isn't open yet, to ide-cel versus lenalidomide maintenance. And I think if we're really going to see the benefit of ide-cel, this is where we'll see it. And then there's another company, another platform making a BCMA CAR T called CARsgen. It's the only one that we have in Canada, other than some local centers developing their own in-house CAR T, not made by a big pharma company, and it's available for advanced myeloma. We may get a slot a month, and the stars have to align for an individual that can be identified, wait 5 weeks or not quite as long for processing, and get this agent. And this is our immediate need, but it's been challenging. I said I would mention CELMoDs. The only thing I would say is these are incredibly souped up IMiDs. Iberdomide is kind of like the new lenalidomide. This is called mezigdomide now. This is an incredibly potent tablet and is often quite well tolerated and will be integrated in with these other immune platforms. And I have personally seen patients whose disease has grown despite a bispecific, despite 2 bispecifics, go into remission with this pill and Dex. So these are not to be discounted. And there's a lot of excitement, and Canada loves pills for treatment. So I won't go into this slide, but this just shows our list of different trials we have for Canadian patients at Princess Margaret. Some of these I've discussed. And my last comment is many promising agents, lots of unanswered questions. I think for patients, referring physicians, GPs, we need to be very conscious of the increased risk of infection. People on these drugs need continuous shingles prevention, whether or not they've been vaccinated with an acyclovir type drug. They need Septra to prevent pneumocystis, septic prevention. They may need monitoring for cytomegalovirus, which is a challenge in allogeneic transplants. And there are a variety of other infections that need to be tackled with good monitoring. This can be surmounted, but it's not what we've needed with our older drugs. So this is my final slide before I get the hook off the stage. I'd like to thank everyone for your attendance. A special thanks to our patients, caregivers, and supporters, our myeloma providers, health professionals, the Leukemia and Lymphoma Society of Canada, Myeloma Canada, the Bloom Chair at my institution, which actually funded our database initiation for CMRG until we could stand on our own 2 feet, the Princess Margaret Foundation, and all our other supporters and donors. This is CMRG. We have 16 sites for our database and up to 21 collaborating for clinical trials. So thank you very much.
Thank you so much, Dr. Reece, for sharing your expertise and insight with all of us today. It's now time for our question and answer period. So if you have not done so already, please be sure to use the question and answer box in your Zoom webinar panel to type your questions. As a note, Dr. Reece cannot answer specific questions about a person's health status, and we will prioritize questions related to research on myeloma. Case-specific questions will not be read aloud during the question and answer period. If we don't get to your question during our question and answer period, a community services lead will contact you directly after the webinar. So some of the questions that we have here, the first question, is myeloma hereditary? And if so, maybe what implication might this have on research?
It's a very interesting question. The cause of myeloma is not well known. There is some link to agricultural chemicals. And there are some reports of hereditary families with a hereditary tendency. It's very clear people will have MGUS or smoldering or myeloma. It's not one type of hereditary. It's certainly not like breast cancer, where there's a gene that can be traced. There are some families that there's a problem in, the problem isn't in the plasma cell. The problem is the families inherit actually a surface marker on all cells that should turn on and off. It's called paratar. No one knows what it does. And the family inherits that this surface marker on all cells, not just plasma cells at all, is always on. And so it provides continual stimulation as something foreign. And in the right context of other factors in these families' immune system, it triggers a monoclonal antibody to fight this marker on cells that's normally there, but it's not there all the time. And that's not the main thing, but it gives you an example of how complex it can be. I think if someone has a multiple family members. We do have a hereditary genetics department at UHN and other centers that will do a deep dive into the family history, deep dive into the literature and other findings, and try to provide some genetic counseling. But it's not simple. It's not that the plasma cells are inherited that just like to get stuck on. But there are occasionally families. We do not recommend routine screening of family members. I mean, but MGUS is very common with age. As we get older, it's very common that one antibody gets stuck on. It doesn't turn off when the trigger is off, which is usually an infection. And by age 50, 2% of the population will have MGUS. By age 70, it's 5% of people will have an extra antibody stuck on just from the immune system being so busy. So, the vast majority will just, that antibody may never go away, but it never turns into anything bad. So you have 5% of everyone over 70 with an extra antibody. You could go nuts worrying about it.
Absolutely. Thank you so much for providing that answer. The next question comes from somebody in the audience. Are these treatments available to those who have been treated with an HMA previously? It was asked after the CD38 antibody approval slide.
What was the question again?
Are these treatments available to those who have been treated with an HMA previously?
Oh, BCMA probably. Yes, it depends on the trial. And I alluded to one trial with Tau. They specifically had a subset for people who had previous exposure to a BCMA targeting agent, which was usually belamaf, which has been on the market in the US. So, now we have people that have had belamaf relapsed. It depends on the trial. Will they allow people with prior BCMA directed treatments? And that is a hot area of research because pharma wants as many people as possible to get the drug. We want as many people. And it looks like, I think the figure was a third of people who've had belamaf responded to talquetamab, and that's not directed to BCMA. It's directed to another antigen. But there's data at ASH. It's not large numbers of someone who's had an anti-BCMA directed CAR T, to which both ide-cel and cilta-cel are directed against that, and then has a BCMA directed bispecific. So there can be responses, and vice versa. Should you give a bispecific first and save CAR T for later? So all of this is being studied, and we don't want a new treatment to close a door absolutely to further better treatments.
Perfect. Thank you so much for that answer. One more question coming live from the audience. What other blood diseases is CAR T cell therapy used for?
It is now part of standard of care for certain settings of lymphoma, and it's funded, which is amazing. CAR T is being evaluated in other heme malignancies like acute lymphoblastic leukemia. And some of the first instances were in children against chronic lymphocytic leukemia. But so-called effector cell therapy is being tried now in solid tumors. It's a little bit different from CAR T. But it's the same principle. My daughter's a research nurse for sarcoma, which is muscle and tendon and joint cancers. And they're doing, they call it effector cell therapy, but it's basically T cells that attack tumor, and they see CRS. So it's being tried in everything, which is a real challenge for resources because we don't have beds. We don't have extra beds to accommodate a whole new group of people who need very sophisticated care. And staff have to be trained. An outpatient, a center that treats patients with these agents has to have access 24 hours. You don't want these patients going to emerge. You want them to go where they can get, if it's early, TOCI right away. So you have to liaise with an emergency facility, and you have to have technically for some of these a bed open all the time in the hospital to crash someone at night to do it safely. All this can be done, but post-COVID, there's no extra buffer in the system, and we're having a major staff shortage. On the other hand, we all want these treatments to get there, and if they are effective, we will get funding for them. It's been easier for lymphoma because CAR T can be curable,
Absolutely.
and then, a cured patient, the challenge is 2 years benefit worth $1 million? If it's me or my family member, darn right. But, technically all myeloma patients could have this. So, but I mean, by moving CAR T and BiTEs earlier, where we're cautiously optimistic, it's not going to be 2 years. What if it's cure? Then it will be, embraced more. But I think right now we are so committed with CMRG and our institutions to get these drugs directly to patients.
Thank you so much for that answer. And the last question of the day before we wrap up is, are you aware, or can you comment on the cost of a stem cell transplant compared to a CAR T cell therapy treatment?
Well, the old cost that was thrown out, a stem cell transplant is dirt cheap. It's $40,000, in Canada. Okay. Compared to $1 million for CAR T. Now, I may be off a bit, with the cost up, and, collecting stem cells used to be about 10 grand. But we do our myeloma autografts mostly as an outpatient. They come in every day to the outpatient facility. They may be admitted for a day or two. So it's been shifted to outpatient. So that's been very important, because then we don't need 15 more beds. We have no space for that. A transplant, even without maintenance, is almost 3 years disease-free. So, a year of lenalidomide maintenance before it went generic was multiple times more expensive than the stem cell transplant. So, and I remember when stem cell transplants were considered breaking the bank, but the health technology field, to my naive point of view, just lowered what they consider acceptable. Now, it's not just saying the treatment works X amount of time and we're going to charge this. Much more complicated. But they used to in my non-specialist view, except a rather cold-hearted measurement of cost per quality life year saved, or incremental cost effectiveness ratio for other treatments. It used to be, again, please don't quote me because a health economist will say I'm way off, but that, okay, $100,000 per quality life year saved, society can bear that. They have lowered it because cancer drugs for all the cancers have gotten so much better, and they're all at least 10 grand a month. So, you have your PD-1 inhibitors, PD-L1 inhibitors for your solid tumors that have drastically improved outcomes, but may need to be given long-term. So you have a treatment that's $1 million. I mean, I think that's, even if you do the basic math, for 9 months with Ida-cel and $1 million, in a system, socialized countries can't do that.
Absolutely.
So now, one other very important thought on a happy note, there are several centers in Canada working on not CAR T cells made by big pharma companies, but made in-house. And optimistically, the goal is that that product will not be $460,000. It'll be $50,000. And I think that's what we're all hoping for, because then it's a bit more than a stem cell transplant, but that becomes very attractive. So I don't want to leave the idea that we'll never, and it's really moving on well in several centers, and that, Ottawa, Edmonton, Calgary, I think Calgary, on the West Coast, some in Toronto. So they're really working, and all countries are doing this. Spain just reported in an abstract that they had an in-house one that they were able to do. It'll be much less. And I haven't had time to, this is just, I think, so wonderful. They are developing platforms that it doesn't take 5 weeks to process them. It takes a week, because it's not so much a problem of people in remission, but we had at our very initial CAR T experience that if someone has really dreadful disease and you have to wait 5 weeks, by the time the product was ready, the person was so ill, kidney failure, looking at dialysis. There was no way we could even offer it. And that is a terribly painful situation to have it there. But even the side effects that are manageable would tip a balance, and we'd lose the patient sooner. And that is a place you don't ever want to go.
Yeah, absolutely. Thank you so much for that answer. And it is good to hopefully generate some hope that,
we have to hang on a little bit more, but every country's interested in its own in-house, and that will be the answer. I mean, but patients can't wait. So if we have these other drugs to keep the lid on the disease till we can get these good drugs. And again, the cell mods are amazing, and it's interesting, how much, if you're looking at the dynamics of a healthcare center, and most people know I'm from the US, I've been in Canada most of the last 35 years. I practiced in both systems. I am committed to Canada. But in the US, where healthcare is a for-profit, why would you ever give a pill?
Absolutely.
We love pills in Canada. So every chance I get with pharma, it's like, when we want your cell mods,
Yep,
you know,
absolutely. Well,
you
thank
don't
you.
have to come in to the hospital and, how can we get these? Because we will like them. We don't need to bring revenue in by giving very fancy treatments. So
Absolutely. Thank
there's a
you so
role.
much for
Yeah.
Thank you so much for your answer and for all of the answers that you provided. If we can advance to the next slide, we'll just do a bit of a wrap up.
Oh, that's
Yeah.
me. Sorry. Sorry. Okay.
No worries. Actually, yes, perfect. Thank you again, Dr. Reece, for being here with us today. I would like to take a moment to remind everyone that we are here for you, so don't hesitate to contact us if you need more information or support concerning this topic or any of our other services. All of our contact information is available on this slide. Also, please make sure to check our website, bloodcancers.ca, to learn more about our upcoming webcasts, podcasts, and more special events. Please note that a short survey will be sent to all participants after this webcast. We would greatly appreciate you taking a moment to fill it in, as it will help us to offer you the most valuable information in the near future. Have a wonderful day, rest of your day, everybody.
Thank you very much. It's been a pleasure.